All right, now we go on to reading the last chapter of what we have to read to for this module. We only have a little bit to read out of here, so we're going to go ahead and get started with that right now.
Purpose. Airway management involves nursing interventions to maintain the patency of a patient's nose, mouth, upper airway, trachea, and lower airway of the respiratory system. The primary goal of airway management is to protect the airway, which will help promote and maintain adequate tissue oxygenation. Standards of care. Principles for practice. Various techniques for airway management are available to promote an open or patent airway, which has the potential to become obstructed by mucus, mechanical obstruction, i.e., soft tissue in upper airway, or a foreign body. Hydration, positioning, nutrition, chest physiotherapy techniques, deep breathing, coughing, humidity, incentive spirometry, and aerosol therapy are non-invasive techniques that are helpful in maintaining a patent airway. When patients are unable to protect their own airway or clear airway secretions with coughing, chest physiotherapy, or other non-invasive techniques, more invasive measures such as suctioning or inserting an artificial airway are needed. An artificial airway is a plastic or rubber device, such as a tracheostomy or endotracheal tube, that is inserted into the upper or lower respiratory tract to facilitate ventilation or the removal of secretions. Patient-centered care. Artificial airways alter patients' ability to communicate, possibly causing feelings of fear, frustration, anxiety, and vulnerability. Recommendations to improve communication for patients with an altered airway include developing alternate means of and establishing an environment that promotes effective communication among the patient, the family, and the members of the healthcare team. Grossbach et al., 2000. Assess for anger and frustration when patients with artificial airways try to communicate, and consider the need for individualized and creative communication methods. Nurses need to thoroughly educate patients and their families using plain language that is culturally appropriate and verify that they understand any procedures or tests. Collaboration with families is essential when providing alternative means of communication for patients. Once communication is established, a patient and family will have more trust in the care provided, which will promote cooperation and rapport. Grossbach et al., 2011. Patients and families who have English as their second language or do not speak English require additional attention from nurses and other healthcare providers to prevent misunderstanding treatment options. Obtain professional translators or other communication aids so patients and families understand the need for an artificial airway and the subsequent treatments. Assess the functional skills of the patient. Ensure that functioning hearing aids are in place and working so communication with a hearing impaired patient is possible. Allow patients to wear their glasses and use communication devices such as picture or letter boards. Assess patient's dominant hand and muscle strength if writing boards are to be used. Grossbach et al., 2011. Evidence-based practice. There are significant concerns regarding defining ventilator-associated pneumonia, VAP, and ventilator-associated events, VEs. The Centers for Disease Control and Prevention, CDC, 2016, developed a lengthy algorithm for clinicians to use to accurately diagnose these complications. The key points in the definition of V are deterioration in respiratory status after a period of stability or improvement on the ventilator, evidence of infection or inflammation, and laboratory evidence of respiratory infection. Patient must be mechanically ventilated for more than 2 calendar days to be eligible for V, CDC, 2016. VAP/V bundles are available to help guide nursing practice, see also Skill 23.5. Key interventions included in these bundles are the following. Elevation of the head of bed, HOB, between 30 and 45 degrees. Daily interruption of sedation and daily assessment of patient's readiness to extubate. Peptic ulcer disease prophylaxis. Deep venous thrombosis prophylaxis, unless contraindicated. Daily oral care with chlorhexidine. Delirium monitoring and management. Early exercise and mobility, IHI, 2012, LAM, 2015. Closed endotracheal suctioning techniques are preferred over open endotracheal suctioning techniques in patients who have undergone open heart surgery. Closed suctioning has fewer traumatic effects on mean arterial blood pressure and pulse oximetry than open suctioning, Austin and Gorgulo, 2014. Closed circuit suctioning has more advantages than disadvantages when compared with open circuit suctioning, such as avoiding loss of positive end expiratory pressure, PEEP, which decreases amount of hypoxemia, costs, and caregiver exposure to pulmonary secretions. Branson et al., 2014. New products are being developed to decrease the risk of biofilm formation on endotracheal tubes, ET. Biofilm is associated with increased risks of developing VAP. These new products include systems that scrape the inside of the ET to remove the secretions. Silver-coated, Guardian-coated, and Genton-coated ETS are also being investigated for their effectiveness in preventing biofilm formation. Branson et al., 2014. Automated cuff pressure control devices used to measure cuff pressures on artificial airways are more consistent and possibly lead to better airway care. Branson et al., 2014. Safety guidelines. Know a patient's baseline range of vital signs and oxygen saturation levels. Baseline physiological measures serve as a means to identify individual abnormalities and recognize the worsening of an illness. Know a patient's medical history. Smoking alters normal mucociliary clearance. Certain disorders such as chronic obstructive pulmonary disease, COPD, asthma, cystic fibrosis, pneumonia, thoracic surgery, chest trauma, and abdominal surgery place patients at increased risk for an obstructed airway. Identify conditions that increase a patient's risk for aspiration of gastric contents into the lung, resulting in airway obstruction. These include the presence of enteral feeding tubes or nasal and oral gastric tubes, a decreased level of consciousness, and a decreased swallowing ability. Use caution when suctioning patients with head injuries. The suction procedure causes an elevation in intracranial pressure, ICP, Galgietti and Paula, 2015. Reduce this risk by pre-suctioning hyperventilation, which results in hypocarbia. This in turn induces vasoconstriction, thereby reducing the risk of elevated ICP. Determine if a patient has a history of nasal problems such as nasal trauma, nasal polyps, deviated nasal septum, or chronic sinusitis. Allergy problems may cause mucosal swelling that narrows nasal passages, which affects the ability to easily pass a suction catheter. Review a patient's respiratory assessments from the past 12 or 24 hours. These are relative baseline measurements that help to distinguish between gradual and acute changes in a patient's status. Perform a systematic pulmonary assessment of upper and lower airways, including identifying respiratory rate, respiratory pattern, accessory muscle use, breath sounds, ability to cough effectively, integrity of the rib cage, and the characteristics of sputum production. Identify and become familiar with the use of equipment available at the agency. Many types of artificial airways, suction catheters, and suction machines are available. Knowing how to operate the equipment before use promotes positive outcomes. Test all equipment before use. Have adequate supplies on hand at the bedside. Equipment must work properly to provide safe nursing care. Determine that the suction machine is generating adequate negative suction pressure and that suction catheters and appropriate equipment are available at the bedside. Know the side effects of medications and other therapies. Some medications such as beta-adrenergic blockers have the side effect of bronchospasm. An adverse effect of opioids and sedatives is respiratory depression. Similarly, too much oxygen reduces the drive to breathe in patients with chronic hypercapnia, elevated arterial carbon dioxide tension. Some position changes affect a patient adversely. For example, in patients with impaired spinal cord innervations of the respiratory muscles, supine positions place the diaphragm at a mechanical disadvantage and increase the risk for aspiration. The installation of normal saline when performing endotracheal suctioning is no longer encouraged and is not a supported practice. Branson et al., 2014. Skill 25.1 Performing oropharyngeal suctioning. Video clip Nursing Skills Online Airway Management Module / Lesson 2. A yank hour, or tonsillar tip, suction device is used for oropharyngeal suctioning, i.e., the removal of pharyngeal secretions through the mouth. Fig 25.1. A yank hour suction catheter is made of rigid, minimally flexible plastic. The tip of the suction catheter usually has one large and several small openings through which the mucus enters with application of negative pressure. The yank hour suction catheter is angled to facilitate removal of secretions through a patient's mouth. Oropharyngeal suctioning only removes secretions from the back of the throat. Perform oral suctioning when a patient is able to cough effectively but is unable to clear secretions, such as for a patient with a neuromuscular injury who cannot manage his or her own oral secretions. Patients with artificial airways and impaired swallowing require use of the yank hour suction device to provide oral hygiene. Fig 25.1 Oropharyngeal suctioning. Delegation and collaboration. The skill of performing oropharyngeal suctioning can be delegated to nursing assistive personnel, NAP. Do not delegate the skill for patients with oral or neck surgery in the immediate postoperative period. The nurse is responsible for assessing the patient's respiratory status. The nurse directs the NAP about appropriate suction limits for oropharyngeal suctioning for a particular patient, example the appropriate suction pressure, expected frequency of suctioning, and expected color and volume of secretions. The risks of applying excessive or inadequate suction pressure. Avoiding mouth sutures, applying suction against sensitive tissues, and dislodging tubes in the patient's nose or mouth. Avoiding stimulation of the gag reflex. Immediately reporting to the nurse any change in vital signs, pulse oximetry, SpO2, sputum, i.e., bloody, difficulty breathing, or discomfort during or after the procedure. Assessment. 1. Identify patient using at least 2 identifiers, example name and birthday or name and medical record number, according to agency policy. Ensures correct patient. Complies with the Joint Commission standards and improves patient safety, TJC, 2016. 2. Identify risk factors for airway obstruction, impaired cough or gag reflex, weakened respiratory muscles, impaired swallowing, and decreased level of consciousness. Risk factors prevent patient from protecting airway from aspiration or clearing secretion safely. 3. Assess for signs and symptoms of hypoxia, anxiety, change in level of consciousness, change in vital signs, decreased SpO2, adventitious sounds. See also box 23.1. Suctioning of oropharyngeal airway is indicated with alterations in oxygenation associated with secretion accumulation. 4. Obtain patient's oxygen saturation level via SpO2, see Chapter 5. Keep pulse oximeter in place. Provides an objective baseline measure of oxygen saturation and an early indication of changes in oxygenation status. Aids in assessment of patient during and after oropharyngeal suctioning. 5. Determine patient's ability to hold or manipulate catheter and his or her knowledge about use of suction catheter and procedure. Encourages cooperation, minimizes risks and anxiety. Identifies teaching needs. Physical factors such as impaired mobility of upper extremities prevent patient from using catheter to help control oral secretions. 6. Assess for signs and symptoms of upper airway obstruction, gurgling on inspiration or expiration, restlessness, obvious excessive oral secretions, drooling, gastric secretions or vomitus in mouth, or coughing without clearing secretions from upper airway. Secretions pool in upper airway, which can cause total airway obstruction and hypoxia. The risk for aspiration of gastric contents and airway obstruction is increased in patients with vomiting, delayed gastric emptying, impairment in esophageal sphincter control, cough, swallowing, or gag reflex, or those receiving enteral feedings. 7. Auscultate for presence of adventitious sounds, see Chapter 6 and Skill 25.2. Determines if lower airway secretions are present and establishes baseline. Nursing diagnoses. Deficient knowledge regarding use of suction. Impaired gas exchange. Impaired swallowing. Ineffective airway clearance. Ineffective breathing pattern. Risk for aspiration. Risk for infection. Related factors/risk factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedure. No gurgling sounds are heard in patient's pharynx on inspiration and expiration. Suctioning is effective. Secretions are removed from large upper airway. Drooling is diminished or absent. Excessive drooling indicates that patient is unable to handle oral secretions. Vomitus or gastric secretions are absent from mouth. Gastric secretions retained in oral cavity increase patient's risk for aspiration pneumonia. SpO2 improves or remains at patient's normal baseline. Removal of secretions helps to improve oxygen saturation level. Clinical decision point. In patients with chronic pulmonary disease, the SpO2 value may remain the same after oropharyngeal suctioning. This baseline value may be lower than the typical normal values of greater than 95%, Grindrod, 2015. 2. Perform hand hygiene. Gather equipment/supplies. Close room door or curtain. Ensures well-organized procedure. Provides patient privacy. 3. Explain to patient how procedure helps clear airway secretions and relieve some breathing problems. Explain that coughing, gagging, or, less commonly, sneezing is normal and lasts only a few seconds. Encourage patient to cough out secretions and show how to splint painful areas during procedure. Practice coughing if able. Gagging or coughing occurs when posterior pharynx is suctioned or as a result of excess secretions. Coughing secretions out of lower airway or posterior pharynx decreases amount of suctioning required. Splinting reduces abdominal incision discomfort during coughing or gagging. 4. Position patient in semi-Fowler's or sitting position. Place towel, cloth, or paper drape across patient's neck and chest. Promotes patient comfort and removal of airway secretions. Towel protects gown and bed linen from contamination by secretions. Implementation. 1. Apply clean gloves. Apply mask or face shield if splashing is likely. Wear gown if isolation precautions are indicated. Reduces transmission of microorganisms. 2. Fill cup or basin with approximately 100 ml of water or normal saline. Helps to clean catheter after suctioning and assesses that equipment functions. 3. Connect one end of connecting tubing to suction machine and other to yank our suction catheter. Turn on suction machine, set vacuum regulator to appropriate setting, infants 80 to 100 mm Hg, children 100 to 120 mm Hg, adults 100 to 150 mm Hg, AARC, 2004. Prepare suction apparatus. Pressures should not exceed 150 mm Hg because elevated pressure settings increase risk for trauma to oral mucosa, AARC, 2004. 4. Check that suction machine is functioning properly by placing tip of catheter in water or normal saline and suctioning small amount from cup or basin. Ensures that equipment functions and lubricates catheter. 5. Remove patient's oxygen mask if present. Nasal cannula may remain in place. Keep oxygen mask near patient's face. Allows access to mouth. Reduces chance of hypoxia. Clinical decision point. Be prepared to quickly reapply supplemental oxygen if SpO2 value falls below 90% or respiratory distress develops during or at the end of oropharyngeal suctioning. Be prepared to use the bag valve mask if patient has serious acute respiratory distress or decline in SpO2. 6. Insert catheter into mouth along gum line to pharynx. Move catheter around mouth until secretions have cleared. Encourage patient to cough. Replace oxygen mask. Movement of catheter prevents suction tip from invaginating oral mucosal surfaces and causing trauma. Coughing moves secretions from lower airway into mouth and upper airway. Clinical decision point. Be careful when using a yank hour tip suction catheter with a patient who had recent oral or head/neck surgery. Aggressive suctioning and excessive coughing should not be used or encouraged in patients who have undergone throat surgery such as a tonsillectomy. These acts can aggravate the operative site, increasing the risk of infection or bleeding. Hockenberry and Wilson, 2015. 7. Rinse catheter with water or normal saline in cup or basin until connecting tubing is cleared of secretions. Turn off suction. Place catheter in clean, dry area. Rinses catheter and reduces probability of transmission of microorganisms. Clean suction tubing enhances delivery of set suction pressure. 8. Wash face if secretions are present on patient's skin. Prevents skin breakdown. 9. Observe respiratory status. Repeat procedure if indicated. May need to use standard suction catheter to reach into trachea if respiratory status not improved. See Skill 25.2. Directs nurse to continue, cease intervention, or choose another intervention. 10. Remove towel, cloth, or disposable drape and place in trash or in laundry if soiled. Reposition patient. SIMS or side-lying position encourages drainage and should be used if patient has decreased level of consciousness. Reduces transmission of microorganisms. Facilitates drainage of oral secretions. 11. Discard remainder of water or normal saline into appropriate receptacle. Rinse basin in warm soapy water and dry with paper towels. Check agency policy. Discard disposable cup into appropriate receptacle. Reduces transmission of microorganisms and maintains medical asepsis. Moist environment encourages microorganism growth. Clinical decision point. Keep catheter in non-airtight container such as brown paper or plastic bag attached to bed rail or in suction canister area. Do not store the catheter where it will come in contact with secretions or excretions, which promote bacterial growth. 12. Remove gloves, mask, or face shield and dispose of inappropriate receptacle. Perform hand hygiene. Reduces transmission of microorganisms to other patients and equipment. 13. Position patient and provide oral hygiene as needed. Promotes patient's comfort. Evaluation. 1. Compare assessment findings before and after procedure. Identifies physiological response to suction procedure. 2. Auscultate chest and airways for adventitious sounds. Presence of lower airway adventitious sounds suggests need for lower airway suctioning. 3. Inspect mouth for any vomitus or remaining secretions. Clear oral airway is necessary to prevent aspiration. 4. Obtain and record post-suction SpO2 value. Compare with pre-suction level. Provides objective measure of effectiveness of suction procedure, AARC, 2004. 5. Use teach back. I want to be sure I explained how to suction your mouth and why it should be performed. Show me how you will use the suction catheter. Revise your instruction now or develop a plan for revised patient or family caregiver teaching if patient or family caregiver is not able to teach back correctly. Determines patients and family caregivers' level of understanding of instructional topic. Unexpected outcomes. Related interventions. 1. Patient's respiratory distress increases. Suction further or implement nasal or tracheal suctioning, Skill 25.2. Evaluate need for other means to protect airway, example oral intubason, oral airway, positioning. Provide supplemental oxygen. Notify healthcare provider. 2. Bloody secretions are suctioned. Assess oral cavity for trauma or lesions. Reduce amount of suction pressure used. Observe catheter tip for nicks, which cause mucosal trauma. Increase frequency of oral hygiene. Recording and reporting. Record the amount, consistency, color, and odor of secretions, number of times suctioned, patient's response to suctioning, and pre-suction and post-suction cardiopulmonary assessment findings on flow sheet or nurse's notes in electronic health record, AIR, or chart. Record patients and family caregivers understanding through teach back for safe oral suctioning. Report any unresolved outcomes such as worsening respiratory distress to the healthcare provider. Special considerations. Teaching. Instruct patient and family caregiver not to allow catheter to fall to the floor. If this occurs, teach patient and family caregiver how to clean or obtain a clean catheter. See home care considerations. Provide information regarding signs and symptoms of worsening respiratory status. Pediatric. Airways of infants and children are smaller than those of an adult. Even small amounts of mucus cause airway obstruction. Smaller suction catheters may need to be used. Hockenberry and Wilson, 2015. Bulb syringes may be used to suction the oral cavity in newborns and infants. To properly use a bulb syringe, compress the bulb before inserting into mouth to decrease the risk of forcing the secretions into lower airways. If the bulb syringe cannot remove the secretions, use appropriate size mechanical suction equipment. Hockenberry and Wilson, 2015. Use lower suction pressures with infants and children than with adults. Hockenberry and Wilson, 2015. Position infants with breathing problems or excessive vomitus in side-lying position to decrease risk of aspiration. Hockenberry and Wilson, 2015. Suctioning, particularly for young infants, should be completed for only 5 seconds because of risk of deoxygenation. Allow 30 to 60 seconds for patient to reoxygenate. Hockenberry and Wilson, 2015. Complete oral suctioning first and then nasal suctioning to decrease the risk of aspiration, particularly for newborn infants. Hockenberry and Wilson, 2015. Gerontological. Patients with dysphagia may benefit from oral suctioning before, during, and after meals. Oral mucosa in older adults is fragile. Tui and Jet, 2014. Use a lower suction pressure if bleeding starts to occur. Older adults are prone to aspiration of oral secretions because of decreased cough and gag reflexes and increased incidence of dysphagia. Tui and Jet, 2014. Home care. Make sure that patient and family caregiver know how to clean and disinfect or change the secretion collection container every 24 hours according to home care protocol. Many agencies seal and dispose of the entire disposable secretion collection canister as biohazardous material. Assess knowledge level of patient and family caregiver to determine amount of instruction required and frequency of home health visits necessary to reach goals. Assess home for the presence of respiratory irritants, including cigarette smoke, dust, pollen, animal dander, mold, and chemicals. Long-term care. As many as 60% of patients who live in nursing homes have evidence of dysphagia, which makes them prone to aspiration. Ensure that dysphagia screens are performed for all patients and that properly functioning equipment is available in the agency. TUI and JET, 2014.